Our speaker is Dr. Heather Hume, who is a professor in the Department of Paediatrics at the University of Montreal in Canada and Makerere University in Kampala, Uganda. She will be speaking on acute transfusion reactions.
Okay, thank you very much for the introduction. I'd like to thank the organizers, Dr. Delaney and Dr. Zeke, for inviting me to take part in this very interesting day. And so I'm going to be talking, as Dr. Delaney said, about acute transfusion reactions. Now, we're here and we all know that transfusions save lives, but there are the caveats. The transfusion should only be given with an appropriate indication. Units must be correctly chosen, correctly prepared, correctly administered. There must be monitoring during the transfusions, and I'm going to mention that several times in my talk. But most of all, what I'm emphasizing today and what I'll be talking about for the next little while is that people involved in transfusion, nurses, physicians, technologists, really need to be knowledgeable about not just the potential benefits, but the potential adverse effects and complications. And there are various kinds of complications. There are complications that are delayed by days, months, and years. But this talk is going to focus on the complications that arise acutely, that is, during the transfusion or within 24 hours of transfusion, and for the most part, either during or within 4 to 6 hours. So that's the focus of the talk. Now, there's some things I hope I'm going to convince you of, and they're here in red, that there is an awful lot more to transfusion safety, and I think we spoke about this earlier today. Of course, the proper testing of the blood of the blood supplier is essential, but there's much more to transfusion safety than that, and I'm going to be talking a lot about transfusion safety at the hospital level. And tied up with that, the importance of monitoring transfusions. I hope by the time I'm finished, you'll be convinced that that is important. And to the extent possible, the transfusion should be given when most personnel is around, so not at night, unless it's really a dire emergency. But I think that even with somewhat limited resources, there are improvements that need to be made, and most of all, can be made. So I'd like to start off with some scenarios, and they are all true. I didn't make up any of these. These are all true stories, and you all have pens and paper, so I'm going to ask you to pick up your pen, take out your piece of paper, and write the answer to the questions that you're going to see. Now, at the end of my talk, I'm going to give you the answers. I'm not going to ask anybody to tell me what they've written down on the page, but I think maybe you'll remember it better if you actually commit yourself to paper. So this is something that occurred at Malago. It was a 49-year-old female with type 1 diabetes and hypertension who had received about 200 mils of a packed red cell over 2 hours. Transfusion wasn't quite done, and she developed difficulty in breathing with an increase in her respiratory rate and a slight increase in her blood pressure. Well, what do you think is the most likely cause of these changes in her vital signs? Could it be TRALI? What is that? We're going to see. Transfusion-related acute lung injury. Could it be TACO? What is that? Transfusion-associated circulatory overload. Could it be pulmonary embolus? Or is it worsening diabetes? So write your answer. Next story. Also something that happened during a transfusion at Malago. This time, a 43-year-old female who'd come in with sepsis, was on antibiotics, had been unstable, but now was stable at the time of this transfusion reaction. About an hour into this reaction, she developed chills and fever, and then this was part of a research study, she told the research assistant that she felt like there was electricity going all through her body. Well, what do you think's happening to this lady? Take your pen. Febrile non-hemolytic transfusion reaction. Acute hemolytic transfusion reaction, or that's a crazy thing for a patient to say. Perhaps this patient had a psychiatric disorder. Now, I'm Canadian, so we're going to have one Canadian story in this, and this is a story I was actually quite involved with, so I know this story well. Now, here's something that the mother wrote. She wrote it on the little girl's website. The girl had acute myelogenous leukemia. And so this is not a breach of confidentiality because it was out there for the world to see. And this little girl, her name was Katie, I believe she was about 4 years old, received a platelet transfusion in the morning. Seems she got a reaction during it. They discovered it had some bacteria in it. And her reaction was that her breathing grew very labored. Her blood pressure dropped, her heart rate rose. She had to be transferred to the intensive care unit. Well, what do you think was happening to this little girl? You know, she was quite neutropenic. So septic shock associated with bacterial infection from her own intestinal bacteria can happen to people who are neutropenic. Septic shock associated with a bacterial contamination of the transfused platelet unit. Or, you know, sometimes those mothers just panic a little too much. Maybe that was what was happening here. What do you think? I think this is my final patient story, and this was told to me by a doctor at Malago. 6-year-old boy, severe anemia, nurse hung a unit of blood and then immediately went away, nowhere to be found. And within 5 minutes, the boy developed vomiting and abdominal pain. So the doctor who told me this story was fortunately nearby, and the mother found the doctor, and the doctor stopped the transfusion. So this time, for each of these statements, true or false. This could be an acute hemolytic transfusion reaction. This could be a severe allergic reaction. This could be due to bacterial contamination. Or, well, every time, you have to answer true or false for each one of these. Or this is most likely not due to the transfusion, because after all, do you really get abdominal pain and vomiting as a transfusion reaction? Okay, so I have one more question for you. Now, this one is a personal thought. What do you think that I think is the most commonest transfusion-related, the commonest cause of a transfusion-related fatality in Uganda? Acute hemolytic transfusion reaction, TRALI, TACO, or anaphylactic reaction? And I'll tell you, obviously, I'll tell you the answers to all of these at the end. Keep them in mind as we now proceed with the rest of the talk. Well, obviously, acute transfusion reaction, if you're going to know if it's going on, you have to recognize it. So it is something new that happens either during the transfusion or 4 to 6 hours, or maybe up to 24 hours. So it's a new sign or symptom or a worsening sign or symptom. And what can the symptoms be? Shaking, chills, rigors, hives or rash, itchiness or swelling. Oh, nausea and vomiting. Difficulty breathing, wheezing, headache, pain, abdominal pain, back pain, pain at the IV site. Anxiety, a sense of impending doom, can actually be a symptom of a transfusion reaction. And then on the signs, changes in any of the vital signs, fever, tachycardia, tachypnea, hypertension or hypotension, decreased oxygen saturation, or hemoglobinuria, which would be a sign of intravascular hemolysis. So there are lots of acute transfusion reactions, and we can't go through them all today, but I am going to try to go through quite a few of them. I'm going to go through some that I think are the most dangerous, fortunately not the most common. They're all a bit on the rare side. We'll see at the end, well, how common or rare they are. But in the list of the most dangerous are the acute hemolytic transfusion reactions, TACO, TRALI, bacterial contamination, anaphylaxis. And then we'll also mention the most common, unfortunately the most common ones, minor allergic reactions and febrile non-hemolytic transfusion reactions are actually not too dangerous. I'm going to put special emphasis on those 2 transfusion reactions that I've highlighted in red, because these are the ones that we really can prevent with means that are currently at our disposal. So I'm going to approach these reactions. Of course, the patient doesn't appear and say, I'm having a febrile non-hemolytic transfusion reaction. You have to figure that out. So patients present commonly with one or more of these symptoms: fever, dyspnea, rash, and other allergy manifestations. So we're going to talk about what if a patient that has any one of these symptoms, what might it be? For example, we'll start with fever. As a physician, the nurse calls you and says, my patient has developed a fever during the transfusion reaction. You're walking to go and see that patient. What's the differential diagnosis that should be going through your head as you're walking to see that patient? What do you have to try and figure out? What is happening to the patient? So the top three are certainly ones that should be going through your head as you're heading to see that patient. Acute hemolytic transfusion reaction, or bacterial contamination of the transfused unit, or febrile non-hemolytic transfusion reaction. It could also be TACO or TRALI. They can present with fever, but that's not their major presenting symptom. Their major presenting symptom is dyspnea, so we're going to talk about them under dyspnea. Of course, any symptom, even if it's a new or worsening one, could be the underlying disease that the patient has, and so you'll always have to keep that in your mind as part of the differential diagnosis. So looking at this chart, first of all, what is the definition of a febrile transfusion reaction, of fever during transfusion? So the definition that's generally agreed upon is that there must be a fever of at least 38 degrees centigrade and an increase of at least 1 degree centigrade from baseline. That does mean that you have to know what the baseline was before the transfusion started. So you needed to have taken the temperature to even know if the temperature has gone up. Now, we tend to think of these as being potentially serious or a little less serious. So if the fever is greater than 39, or if the fever is less than 39, so about between 38 and 39, but accompanied with other symptoms, particularly things such as hypotension or Rigors, then you really have to think about acute hemolytic transfusion reaction or bacterial contamination. They have to be high on your list, and you have to think of those possibilities. However, if the fever is just between 38 and 39 and there are no other symptoms, the most likely probability is that this is a febrile non-hemolytic transfusion reaction. Just to remind you, how can an acute hemolytic transfusion reaction manifest? Well, we often think of it manifesting with a lot of very serious things: anxiety, apprehension, pain, nausea, vomiting, dyspnea, hypotension. But fever might be the only sign, so you need to keep that in mind. And of course, it is always potentially fatal. Almost always an acute hemolytic transfusion reaction is due to ABO incompatibility, and almost always ABO incompatibility is due to human error, which means it is preventable. Occasionally, the error might be at the level of the blood supplier, with the blood bag being wrongly labeled. More often, the error is at the hospital level, and the error can be in many places. Just a whole list, really, right from the very first thing you do to the last thing you do. Getting the patient's specimen, making sure it's properly, we're going to have a whole session on that just a little while from now, right through technical and clerical errors in the blood bank to when the nurse is hanging the unit, giving the wrong unit to the wrong person. Roughly about 2/3 of the errors occur in the clinical area, about 1/3 of the area in the laboratory. But often what happens is that there are errors at multiple spots. When something really bad goes wrong, often it's not just one place, but along the chain, several things have happened. Well, how do we prevent these reactions? We transfuse only if it is clearly clinically necessary. We have to know about them. We have to be educated. We have to educate our staff. And I would say you should educate your patient as well. Tell your patient if they're feeling unwell during the transfusion to be sure to communicate that. Implement and use proper procedures at every step along the way. And we're going to, I think, in some of the other talks over the course of today and tomorrow, hear a lot more about this. And then, as I said, we need to monitor the transfusion. And we're, I think the next thing I've got for you here is a transfusion form that we hope this or something like this. We've developed this at Malago, but we're hoping in Uganda something similar to this could actually be part of the transfusion form, where the nurse or the physician who's administering the transfusion will write in these vital signs at these various times, and most importantly at the start. And then most severe reactions, or often a severe reaction, will happen within 15 minutes, not all the time, but that first 15 minutes is very important, so that's why there's monitoring after 15 minutes, and then at some other point during the transfusion and after it. What about bacterial contamination, or what we call septic reactions? There's the list of the clinical manifestations, and you might almost say that I just changed the title of the slide, that it looks a lot like acute hemolytic transfusion reactions, and that is true. They can be very difficult to distinguish clinically. But by the way, bacteria in a blood bag, how does that happen? Well, it can happen at many steps along the way. There are donors that could be bacteremic and completely asymptomatic. Grace mentioned this morning about the importance of the cleansing of the skin at the time of donation. Rarely there are blood bag defects, contamination during processing. Thawing in contaminated water, that's at the hospital level, and non-adherence to standards, that happens at the hospital level too. And so how do we prevent these reactions? It all starts off the same. Only give the transfusion if it's really necessary. Be educated. And here, the supplier, proper skin cleansing, and at the hospital, if you open your unit, for example, of red cells, you can take alpha-naliquat, you can put that unit back in the fridge, but you must use it within 24 hours. And unfortunately, I've seen even at Malago where the units may sit longer than 24 hours once opened and then are used. That's a perfect recipe for having a bacterially contaminated unit. Very occasionally, visual inspection, and we talk about visual inspection being important, and this is one of the reasons. And occasionally, you get something like this. This is taken from the journal Transfusion, and you can see this bag's all puffed up, and it really shouldn't look like that. And this was a gas-forming bacteria. It happened to be Klebsiella. So looking at a bag, and if a bag really does look not good, then obviously you should not use that bag for transfusion. So that leaves us with the third one, the febrile non-hemolytic transfusion reaction. It's really a diagnosis of exclusion. So it occurs with fever or sometimes chills and rigor without fever, but there should certainly be no other associated symptoms, no hypotension, no dyspnea, and even the chills and rigor should not be too important. What causes these reactions? There are two basic pathophysiologies. It can be a reaction between the donor white cells and recipient antibodies, so an immunologic reaction, or it can be a reaction to cytokines. It can be the cytokines in the blood bag. Cytokines accumulate with storage of the blood units, and these cytokines can cause fever. So the longer a unit's been stored, the more likely this kind of reaction might be to occur. So it's benign and self-limiting, as I said. So with that, you're left with the important question. You've gone to see your patient for the fever. You've wondered what it is. We'll suppose that this reaction happened during the course of transfusion. And the question always is, can we restart this transfusion? Oh, but first, so what do you do when you're called? You must always stop the transfusion. You must always take the patient's vital signs. And again, you want to be able to compare that with what they had before. You want to check all the identification. You're looking to see if there could be a clerical error that in particular could be the cause of an ABO, acute hemolytic transfusion reaction. You'll probably give something for the fever, and you'll want to have a physician evaluate the patient. But it's at this point, I think my next slide, that the question is, can you restart? My answer to that would be you need to be very prudent about restarting such a transfusion. So sometimes you can, but only and only if all these things are in place. You have checked for clerical errors and there were none found. This is just a personal idea, but I would not restart a transfusion if the fever began within 30 minutes at the beginning of the transfusion. I'd be concerned that it was one of the serious things. The temperature should be less than 39, so your temperature rise should bring you up to a level that's less than 39. There should be no other signs and symptoms than the fever, and it is essential that if you are going to restart, that the patient be carefully monitored so that the transfusion can be immediately stopped if a fever recurs. So if all of that is true, with careful observation, you can restart. But if you have any doubts about any of this, the possibility of an error or bacterial contamination, it would be more prudent not to restart that transfusion. Okay, let's go from fever to dyspnea. And what are we thinking if the patient has trouble breathing? Well, the acute hemolytic transfusion reaction can present with difficulty breathing, as can a bacterial contamination. But here, so you do need to still think about those possibilities, but now it's transfusion-associated circulatory overload or transfusion-associated acute lung injury or anaphylaxis that become highest on the list that you're going to be thinking of as you're evaluating this patient. Again, it could be the underlying illness. So in this guy, oh, by the way, I meant to tell you that those of you who got these books, I've taken these tables directly out of this book. So you will find them in here. I've plagiarized completely this. And any of you that didn't get one of these books but comes to the workshop on acute transfusion reactions, I do have some stashed away for the people coming to that workshop. So if there is dyspnea or decrease in oxygen saturation, if it occurs with hypertension, and if it occurs sometime after the transfusion has begun or after the end, then chances are this could be TACO, transfusion-associated circulatory overload. On the other hand, if it's hypotension, and if it can occur in this time period, but if it occurred quite early in the transfusion, before in fact you'd given a huge volume, then you would be thinking more likely that this might be transfusion-related acute lung injury. And if it occurs early, just don't forget the other things that need to be considered, and the three of them are named here. So TACO, what is it? Well, it's exactly what the name says it is. It's transfusion-associated circulatory overload. And it comes in patients probably that are somewhat vulnerable to start with, and then with either excessive and or rapid transfusion. It looks like circulatory overload from any other reason. Who are the patients that are at risk? The very young or the old, but it has been described at all ages. Those with impaired cardiac, renal, or pulmonary function. Those who might be in a positive fluid balance before the beginning of the transfusion, and those with chronic anemia and therefore increased plasma volumes. I said the manifestations are the manifestations of circulatory overload under any circumstances, and they are listed there along with the changes in the vital signs, which might be the first things you notice during the monitoring of the transfusion. Now, unfortunately, here in Uganda, I think it is difficult to get chest x-ray in this situation. If you can get a chest x-ray, you will see the signs of cardiogenic pulmonary edema. And I'm not a radiologist, but I think you can tell that the lung fields here look like they're a lot more bothered than the ones here, pre-transfusion, post-transfusion, and that the size of the heart has increased. So they're typical signs of cardiac overload. Again, to prevent it, it's always the same two. 1 and 2 are always the same. But here we want to identify our patients who would be at risk for TACO and take some extra precautions. For every patient, you should specify in writing the speed with which the transfusion should be given. But it's all the more important that that be specified in writing for the patients that are at risk. You may want to give them a smaller volume. That doesn't mean that you put your blood in over 10 hours. It means that you give a smaller volume in the allowed 4-hour period. Certainly, you give 1 unit at a time, you reevaluate. Actually, that should be done for everybody. And you may want to give a diuretic at the beginning of the transfusion for the patients that are most at risk. And again, as always, monitor the transfusion so that you can find out early if your patient is getting into trouble. What about TRALI? Now, this is a bit of a difficult concept. It's an acute transfusion reaction that occurs within 6 hours of transfusion, and it's a new episode of this thing called ALI. ALI is acute lung injury, and there is a very strict definition of ALI. It comes from the intensive care community, and it's hypoxemia, bilateral infiltrates with no evidence of circulatory overload. So this is non-cardiogenic anemia. And to make the diagnosis or a sure diagnosis of TRALI, you should have no underlying risk factors for ALI. And the underlying risk factors for ALI are multiple. And in fact, you might say almost every transfused patient might have some of these. So if they are there and you still think that the event that has occurred during transfusion could be this transfusion-related acute lung injury, then that's called possible TRALI. And this chest x-ray looks a little bit like the other one, but in this case, you don't have the cardiomegaly that you saw in the first one. But I just tell you a little bit about the cause of this transfusion reaction. It's thought to have two different causes. Both of the causes end up in a final common pathway that causes lung injury. So the final thing that happens is pulmonary endothelial damage with a capillary leak, and there are two ways of getting there. One way is, both ways include an activation of neutrophils, but one way is where the donor has antibodies that can react with the white cells, and this immunologic reaction of the donor antibody with the recipient white cell then activates the neutrophil, and that goes on to cause the pulmonary damage, or maybe even activates not just the neutrophil, but some of the other white cells. A second mechanism is, again, accumulation of bioactive lipids in the stored blood, and that these can directly lead to the cause of pulmonary endothelial damage. Now, it's interesting to think who has these antibodies for the antibody hypothesis, and for the most part, it's previously pregnant females. So that makes me think that we might actually see a little more TRALI in North America and Europe than you might see in Africa or here in Uganda, thinking of your donor population. Now, this is the product part of it, if you will. There are also patients who are at risk, and I'm not going to belabor that here, but the meaning of this slide is just to say that each patient would have a certain threshold. Again, I think my pointer's not working anymore, but there's a kind of threshold. And for any given product, some patients will be more or less susceptible to TRALI. And again, there's a list on the left of patients that will be more susceptible. How do we manage this? Same, stop the transfusion, take the vital signs, check the patient ID. Do not restart the transfusion. Thank you. Maybe I just wasn't pressing the right place. And here, I would suggest you should not restart the transfusion of a patient that's having respiratory difficulty. Okay, just one slide now on allergic transfusion reactions. Again, a table from that same book. Tend to divide allergic transfusion reactions into those that are considered minor and those that are severe. So minor is considered one that has only hives or urticaria, or only itching on less than 2/3 of the body's surface. And sometimes it starts after the end of transfusion, but if it starts during transfusion, you can stop it, give an antihistamine if your patient is doing better, under close observation, restart. However, if more than 2/3 of the body is covered with the cutaneous reaction, or certainly if there are any other symptoms, cough, stridor, any respiratory distress, well, then you're really into the emergency treatment of a severe allergic reaction, and obviously, definitely that transfusion does not get restarted. So what are the approximate frequencies of these? Even in countries where a lot of studies have been done, it can be a bit difficult to know the exact frequencies, and they do vary from one study to another, different kind of blood products, different kind of patients. So these are very approximate. But in North America, febrile non-hemolytic transfusion reaction, approximately 1 in 30 units red cells, approximately 1 in 100 units of platelets. We did a study at Malago of red cells and whole blood. We studied 500 units, and we had these sort of febrile reactions in about 1 in 25 units. We've also done a study of platelets, and we're still analyzing that, so I can't tell you that reaction. Allergic, had to be about 1 to 3% of units. Again, it depends on how much plasma the unit has. and in our study at Malaga it was almost exactly the same. Acute hemolytic transfusion reaction, very rare in North America because of all the safeguards that have been put in place over about the last 20 years. We're going to hear more about them, but I fear that it's not so rare here in Uganda, and we had 2 episodes of that in our study of 500 transfusions at Malaga. TACO, again, quite variable, but actually seems to be probably relatively common. In our study, it was about 1 in 200 units, so one of the more common ones. TRALI, rare, about 1 in 100,000, and I really have no idea here in Uganda. Bacterial contamination, it is rare, more likely to occur in platelets because they're kept at room temperature as opposed to red cells. Studies that have been published from Ghana and Kenya suggest that in red cells it may be as high as 10%. I think that's because they kept on going back into those red cells after 24 hours. And the study we've done on platelets at Malaga is specifically to look at that question. So hopefully soon we'll have some answers for you for that. And now I think we're at the answers. So take your page, see if you got them right. This is the dyspnea and hypertension during transfusion, and it was TACO. And this woman responded very nicely to treatment with diuretics. But I think she would have got into a lot of trouble if she hadn't been on our study and nobody had been watching what was happening with her. Another woman from our study, and what was this? This was an acute hemolytic transfusion reaction. This woman had been said to be group AB, and so she was receiving AB blood, and she was actually group O. Again, I think this woman could have got into more trouble than she did if she hadn't been in this study. My little girl in Canada, this was septic shock associated with bacterial contamination of the transfused platelet. The organism in question was Serratia marascens, and sadly that little girl died from this transfusion reaction. What about this boy? Nausea and vomiting literally within minutes of starting the transfusion. Oh, so what are the statements? A, B, and C, all true, and D, as we've seen, is false. Indeed, this can be a transfusion reaction, and this was an acute hemolytic transfusion reaction. And that boy would definitely have been at risk of death if things had gone on a little longer. So what do I think? Well, I've just shown you 2 cases of acute hemolytic transfusion reactions, and I personally have heard of 3 deaths since I've been coming to Uganda. So I think at the hospital level, this is a major problem. And this is when I say we need to do something, but we can do something. This is something that can be prevented in every hospital in Uganda. And I hope we'll talk a little bit more about that in the course of the next 2 days. So we need to be educated, we need to know what to look for, we need to know how to prevent it to the best we can, and how to treat it quickly if these reactions do happen. And with that, I thank you, and I encourage you to save these lives by being not just a blood donor, but being a repeat blood donor. Thank you.